Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. Today we'll be discussing on the second part of ischemic heart disease, that is angina, or it is also called stable angina, typical angina, effort angina, or also called as angina pectoris. So there are many different names for this angina. As usual, we'll be discussing under the heading definition, etiology, pathophysiology, clinical features, investigations, differential diagnosis, treatment, and complications. Now we know very well angina pectoris is a symptom. It is not a disease. So classic angina or angina pectoris or stable angina is characterized by substernal or precordial pain, which is squeezing in nature, which is aggravated by emotion, stress, or physical exercise, and relieved by rest or by nitroglycerin. May radiate to left shoulder, left arm, all along the inner side, right up to tip of little finger. May radiate to right shoulder, right upper arm, all along the inner side, or radiate to neck, angle of jaw, or towards back, interscapular region, paravertebral region, or may radiate retrosternal right up to xiphisternum and epigastric. Usually not associated with any additional symptoms, but may be associated with vomiting, perspiration, prostration. This pain usually lasts for 10 to 15 minutes, not longer. May be associated with nausea, vomiting, and diaphoresis. So angina pectoris is basically a symptom. There are different terminology which are being utilized, or we call types. Classical we call is a classical or exertional or typical or stable or effort angina. In acute coronary syndrome, we use the word unstable angina. There is one another variety of angina we call variant angina or Prinzmetal angina or vasospastic angina. There is one called as angina equivalent syndrome. Then there is angina syndrome X or cardiac syndrome X, silent ischemia, nocturnal angina or angina decubitus. And there is one more word utilized, abdominal angina and Heberden's angina. Heberden's angina, sorry, not Heberden, Heberden's angina. So these are the different terms which can be utilized, or you can call different types depending upon the description, etc. You use those terminology. By and large, we use the two common terms, typical angina, atypical angina, or non-cardiac chest pain. So typical angina, we have already given you the description. And if that angina comes at a specific amount of exertion, it is called stable angina. When that angina frequency increases, duration becomes shorter, duration of the pain becomes longer, frequency becomes more, which comes even at rest. Then we call that as unstable angina or pre-infarction, or also the term utilized was crescendo angina. If after treatment still anginal pain is persistent in spite of a proper treatment, then it is called intractable or refractory angina. Variant angina is secondary due to vasospasm of coronary artery, where you don't have a elevation of biomarkers, but there will be ST segment elevation which will be reversible as soon as the coronary artery spasm is relieved. And this angina can come at rest also. There is one variety called as a silent ischemia, where person do not get the pain, but there is a clinical evidence of ischemia by ECG or by treadmill testing. Angina decubitus comes in supine posture. Nocturnal angina comes during sleep. Abdominal angina is because of decreased blood supply to mesenteric artery, resulting into ischemia, producing abdominal pain. And Herbedens angina is pain in a breast region during exertion and relieved by rest. These are the different words which are being utilized. As far as severity is concerned, it is divided into class 1, 2, 3, 4. That is, no angina with ordinary physical activity. Angina comes only on strenuous exercise or prolonged exertion. Then it is called class 1. If there is an early onset and there is a limitation of ordinary activity, where person gets pain by walking for 2 blocks or climbing 1 flight of staircase, it is worst after meal, on exposure to cold temperature or emotional stress, then we call as class 2. If there is a marked limitation of ordinary activity, then it is called class 3. And if it comes at rest, then it is called class 4. Usually the angina which comes without any physical activity and at rest falls into a group we call as unstable angina. So this is the grading as far as severity of angina is concerned. Etiology we know very well. One of the most common etiology is obstruction of the coronary artery by atheroma. Second common mechanism is spasm of coronary artery, and that we call as Prinzmetal angina or vasospastic angina or variant angina. There may be thromboembolic phenomena and coronary artery may be blocked by embolus. Not very common, rare condition. But if unstable atheromatous plaque ruptures and there is a formation of thrombus, then it is secondary due to atherosclerosis. So acute obstruction, or we call acute coronary syndrome, can be because of unstable plaque rupture. And that unstable plaque rupture can be because of secondary due to stress, sudden shoot up of blood pressure, or maybe because of inflammation secondary due to H. pylori or herpes simplex. Or you can have inflammation or involvement of coronary artery by inflammation like syphilis, where you get a osteal stenosis, so it is called coronary osteal stenosis, very common in syphilis. And occasionally coronary artery may be involved by vasculitis, say like example SL or collagen disorders. Second mechanism or second cause of ischemic heart disease producing angina can be because of imbalance between supply and demand. So if demand increases or supply decreases, then also you can get anginal pain. We have already mentioned in before the ischemic heart disease chapter, increased demand, classical example, tachycardia, tachyarrhythmias, or increase in size of myocardial tissue like hypertrophy. Classical example, hypertension, aortic stenosis, etc. Or increase in tachyarrhythmias like thyrotoxicosis, anxiety, exercise, those groups. Also increased demand can be during pregnancy. There are many factors which we already, and probably we might have a slide in this also. Decreased flow of oxygen will decrease the demand supply. and there may be decreased oxygen supply because of anemia or secondary due to severe hypoxemia or shock stage. Hypoxemia can be because of respiratory condition, cardiovascular condition, etc. Coronary artery involvement can be congenital or acquired. We have already discussed in ischemic heart disease chapter. In congenital, single coronary artery or both coronary artery arising from single cuts, transposition of great vessels means aorta is arising from RV, so it receives deoxygenated blood. Congenital coronary artery stenosis or coronary arteries arising from pulmonary artery. Rare anomalies, but can produce ischemic heart disease and person can have anginal pain. We already mentioned atherosclerosis, coronary artery spasm, osteal stenosis and vasculitis. So classical example of spasm, variant angina, when there is major occlusion not complete, it will produce unstable angina, and when there is a complete occlusion, it will produce acute MI. As far as atherosclerosis is concerned, we already mentioned modifiable cause, non-modifiable cause. Among non-modifiable cause, advanced age, sex, female more prone to male, strong family history, race and heredity. While among modifiable or we call controllable causes, dyslipidemia, smoking, alcohol, hypertension, diabetes, obesity, together they become cardiometabolic syndrome. Dietary factor, thrombogenic factor, sedentary lifestyle, mental stress, anxiety, anger, infection like chlamydia or herpes simplex, homocysteine elevation, inflammatory markers are elevated in inflammation. So CRP, HSCRP elevation also becomes a risk factors. These are the figure which shows you old age more prone to male, more common than premenopausal woman. After menopause, almost remains same. Strong family history. Smoking, hyperlipidemia, hypertension, diabetes mellitus, sedentary lifestyle or we call lack of exercise, blood coagulatory factors, personality, obesity, etc. can be major factors. Angina can be precipitated by physical exercise, exposure to cold temperature, strong emotion, consumption of heavy meal, tobacco consumption or even environmental tobacco smokes, sexual activity, stimulants like cocaine or amphetamine, and usually it is more early in the morning, circadian rhythm pattern. This already we have shown you before that decreased supply because of coronary artery involvement, coronary artery spasm, thrombosis, or cardiac demands like tachyarrhythmias, congestive heart failure, severe valvular heart disease, non-cardiac condition like anemia, asthma, all this will have a decreased oxygen supply. COPD, hypovolemia, shock, hypoxemia, pneumonia, etc. An increased demand classical in case of LVS secondary due to aortic stenosis, hypertrophic cardiomyopathy, tachyarrhythmias, tachycardias, or increased demand in anxiety that will also end up with tachyarrhythmias, hypertension, hypothermia, hypothyroidism, there is an increased demand, severe physical exertion or drug use like cocaine, ephedrine, etc. Same thing is repeated here. At your leisure time you can go through. This is increased demand. This is decreased supply, increased demand. So this cause is already we have mentioned before. Myocardial ischemia can result from, we have already mentioned, few mechanisms. One, because of decreased coronary blood flow, congenital anomaly. Because of congenital anomaly, myocardium does not receive oxygenated blood. It will receive more of deoxy blood, or there is an increased demand, or there is a decreased supply. Because of imbalance of this supply and demand imbalance, these are all the causes where supply is reduced. These are where there is an increased demand because of increase in heart rate, increased contractility, or increased stress on the myocardium. So because of this imbalance, now ischemia will result. So these are the factor which increases the demand, these are the factor which reduces the supply. And if there is an imbalance, demand is more than supply, then ischemia will result. So always there is an imbalance. These are the mechanisms which we already mentioned before in ischemic heart disease. I'm skipping over all these slides. So spasm, increased tone in the muscle, or there is increased demand and decreased supply. Vasospasm, occlusion, total occlusion. Stable plaque, unstable plaque, what it will result into. We already discussed before. Increased blood load, increased oxygen demand, narrow blood vessels, more work in less oxygen supply. So demand is more, supply is less. Anaerobic metabolism, accumulation of lactic acid, which will have effect on cell permeability, and there will be release of substance like histamine, kinins, we call bradykinin, etc., which will stimulate the nerve fiber and results into pain. And that pain we describe as anginal pain. Classical description we have already described before, that anginal pain is a precordial or retrosternal pain which radiates to a specific site. We'll mention those, usually lasting for 5 to 10 minutes. Heaviness or choking sensation or suffocating sensation. Severity wise, mild to moderate usually, very rarely severe. Usually severe chest pain goes more in favor of unstable angina or MI. Pain can radiate to left shoulder all along the inner side of the left arm up to little finger, or may radiate even to right shoulder and right upper arm. It can also radiate to jaw, throat, and retrosternal region right up to epigastrium, and may radiate to back in interscapular region. Usually aggravated by exercise, anxiety, heavy meal, or on exposure to cold. It is relieved by rest or by coronary vasodilator like nitroglycerin. May or may not be associated with other system symptoms like nausea, vomiting, and diaphoresis, which is not very common in angina. It is more common in acute coronary syndrome. It is also called stable angina, effort angina, typical angina, or angina pectoris. Whatever we have discussed before, same thing is again given a description: site, nature, radiation, duration, aggravating factor, relieving factor. So as far as aggravating factor is concerned, emotion, exertion, exposure to cold weather more common, heavy meal, smoking. We have mentioned nausea, vomiting, and prostration. Along with that, person can have fatigue, shortness of breath, anxiety, sweating, dizziness, etc. can be there. But usually it is not common in angina, it is more common with acute coronary syndrome. So typical angina, description of the pain can be pressure, heaviness, tightness, squeezing sensation. All these are the different description. Typical Levine sign, person will be holding the chest. That is called typical Levine sign. And these are the different distribution. Retrosternal right up to neck, radiates to the neck. Here, radiate to the shoulder, epigastrium, radiates to the arm, radiates to the neck. Only pain can be there in the inner side of the arm and the shoulder, more common in the left shoulder, or posteriorly intrascapular region, or we call interscapular region. We have already mentioned the associated finding like nausea, vomiting, shortness of breath, anxiety, sweating, dizziness, fatigue. All those symptoms can be there. Difference between typical angina and non-cardiac chest pain we have already discussed many times before, but still I am repeating again. It will be helpful to you. Typical pain in stable angina, or we call angina pectoris, which is heaviness, suffocating sensation, someone is sitting on the chest, etc. While in a non-cardiac chest pain, usually it is stabbing in nature or a sharp pain, pricking pain. Duration in angina is 5 to 10 minutes, while here it is from short period to a very long period and continuous pain. Onset is on exertion in case of angina, while in case of non-cardiac pain, onset can be rapid. Location is substernal and precordial, and there is no local tenderness in case of angina, while there is usually it is called pinpointing pain or finger pointing pain, and there is a local tenderness in case of non-cardiac chest pain, or we call muscular pain or costochondritis. Pain will be aggravated by exercise or by anxiety or by heavy meals or on exposure to extreme cold, etc. While pain is aggravated in case of extracardiac, or we call skeletomuscular pain, by movement or by deep inspiration, expiration, coughing, or movement of the chest wall. Autonomic symptoms are usually present in stable angina like nausea, vomiting, prostration, while it is usually not seen in case of musculoskeletal pain. Fever may be present in case of costochondritis. Pain in angina will be relieved by rest and by nitroglycerin, while pain in non-cardiac chest pain, or we call musculoskeletal pain, will be relieved by analgesics or by local applications. So again, same difference between the two: ischemic origin, non-ischemic origin. So this favors ischemic origin, this favors non-ischemic origin. We have already mentioned all those differences. So at your leisure time, go through. This is a character, this is a distribution, this is a provocating factor. Here it is usually by movement of the chest. This is usually laterally pinpointing, or we call finger pointing. The character of the pain is sharp pain, pricking pain. Very, very typical. We have already described this before. That is severity, class 1, class 2, class 3, class 4. We have already described. We have given this description of all these different varieties: stable angina, refractory angina, Prince metal angina, angina equivalent, angina syndrome X, silent, nocturnal. There is some other terminology, or decubitus angina, Haberden's angina, second wind angina, unstable angina, crescendo angina, etc. Or even abdominal or intestinal or mesenteric ischemia angina. So we'll be using some of those. Refractory means when the person gets chest pain, which cannot be controlled by combination of multiple medical therapy, then we call that as a refractory angina, which people invariably requires angioplasty or coronary bypass surgery. Chronic angina, meaning if anginal pain comes repeatedly and the angina is lasting for a very long period, then we call that as a chronic angina. That terminology is nearly gone. Variant angina, I have already given you the description. It is secondary due to vasospasm. It occurs at rest, very commonly during sleep. It is a spasm of the coronary artery. Usually there is a small atheromatous plaque. There is abnormal reactive and hypertrophied segment of coronary artery. Secondary to anxiety or a non-specific etiology, artery undergoes spasm. There is an imbalance between vasodilator and vasoconstrictors. And there is an increased calcium entry into coronary artery, resulting into that spasm. Very frequently it is due to exposure to cold, emotional stress, hyperventilation. Some of the drugs, smoking, cocaine use can precipitate vasospasm. Diagnosis is done by ST segment elevation, which is transient and completely reversible. As soon as the spasm is relieved either by rest or spontaneous or by drugs like nitroglycerin, ST segment comes back to normal. There is no elevation of troponin. Classical diagnosis of coronary artery spasm or vasospastic angina, or we call Prince-Metal angina. You can demonstrate this by a provocative test called ergonovin test, or by using methacholine, or by using acetylcholine. Withdraw nitrate and CCB prior to doing this test. So you will be able to demonstrate coronary artery spasm producing ST segment elevation. So if a person do not have an ST segment elevation and you are suspecting coronary artery spasm, you can do this provocative test. By and large, the treatment requires is adjustment of the dose, coronary artery vasodilators, mainly CCB are the most commonly drug which are being utilized. Second common drug which utilized is nitroglycerin, or we call isosorbide dinitrate. Avoid alcohol, cocaine, cigarette smoking, exposure to extreme cold, mental stress, etc. So CCB are the first drug of choice, in which comes verapamil and diltiazem. Nitrates are commonly utilized during acute episode, but by and large it is not utilized for a chronic management. So combination of diltiazem and nifedipine, or we call verapamil, is a better drug. Beta blockers are not giving good results in coronary artery spasm disorders. There is a second variety of an angina we call as an angina equivalent, meaning person in spite of chest pain, they develop dyspnea or fainting episodes or fatigue during exertion, and it is relieved by rest and nitrate. That's why it is labeled as angina equivalent. So instead of pain, person develops dyspnea or fainting episodes or fatigue. So patient with exertional dyspnea rather than on exertional chest pain, that is called as angina equivalent syndrome, and that is very frequently caused by exercise induced left ventricular dysfunction. So that is angina equivalent syndrome. I've given you already the description. Syndrome X is also called microvascular angina, where there is a typical exertional anginal pain with positive exercise test. Anatomically, when you do coronary angiography, all coronary artery are normal, and there is a reduced capacity of vasodilatation in microvasculature. Long-term prognosis is usually good, and you get a very good response to CCB and beta blockers. On coronary angiography, usually you don't demonstrate severe occlusion, or we call non-occlusions, less than 50% of occlusions. So by and large, on angiography, the report will be normal angiography. And you can demonstrate the signs of ischemia during treadmill testing or stress testing. And that is given a name angina syndrome X, or microvascular angina. Silent ischemia means person do not get chest pain, but there is a clear-cut evidence of ischemia either on ECG or on exercise tolerance test or stress test, or there may be a change in a biomarker, elevation of biomarkers. Then we label that as silent ischemia or silent angina. So this is dangerous because person do not get chest pain. That's why it becomes very difficult to diagnose. Only it can be diagnosed while taking ECG or while doing an exercise stress testing, or sometime if you put them on a Holter monitoring. So that will be the way you can make a diagnosis. Nocturnal angina will occur during sleep. Classical example in case of aortic regurgitation. While decubitus angina is angina which is aggravated by lying down posture and relieved by sitting posture or standing posture. That is decubitus angina. There is a slight difference between two. In nocturnal angina, it is during sleep with long-standing supine posture, while angina decubitus will be aggravated by lying down even during daytime for a short period. So nocturnal angina is usually during night. Classical example in case of coronary arterial stenosis, in cardiovascular syphilis, along with aortic regurgitation. So whenever the common cause of aortic regurgitation, one of the common causes is syphilis. So in presence of syphilis with aortic regurgitation and coronary arterial stenosis, chances of nocturnal angina will be more. And we already mentioned it is almost similar like angina decubitus, where angina is on supine posture or on lying down posture, and it is relieved by sitting or standing posture. There is one another word utilized is second wind angina, that it occurs on initial exertion, but when person continue further, it subsides without a patient resting. So by and large, a classical angina person gets such a severe pain that he will take a rest while doing an exertion, and after taking rest the pain subsides. While here, even without the patient resting, the pain becomes less on continuous exertion, and it is not uncommon and maybe condition which will misdiagnose, because when a person says this, usually person say that even I continued walking, my pain subsided. So there will be misdiagnosis, and this is called Levine test. So angina pain will be relieved by carotid sinus massage, and if you get this Levine test positive, it will go in favor of what we call as a second wind angina. Odd condition, but do keep it in mind. If someone comes with this, if person is having anginal pain, you give a carotid sinus massage, the anginal pain will be relieved by that. We call that as a Levine test. Heberden's angina is commonly seen in female. It is on exertion. It is while climbing a hill or soon after eating. The pain is commonly in a breast region, and when a person takes rest, usually anginal pain subsides, and that is described as Heberden's angina, and it was described in 1767. But you should be aware of this type. Unstable angina, we have already told you that unstable angina is an anginal pain which comes even at rest, or during stable angina. If the frequency becomes more, duration of the anginal pain becomes longer. Angina comes even with very small exertion or even at rest, and very frequently that anginal pain is not relieved by rest or not relieved by nitroglycerin. You should suspect acute coronary syndrome, probability of unstable angina. So stable angina pattern is not usually followed, and it occurs even without physical exertion, and not relieved by rest or by nitroglycerin. Suspect unstable angina. Previously, it was also told second term was utilized for unstable angina, crescendo angina, or pre-infarction angina. So, pain is longer than 30 minutes, not relieved by rest, not relieved by medication, which is coming on also even at rest. Do suspect unstable angina. And if there is ST segment changes without any elevation of cardio biomarkers, then suspect unstable angina. Acute mesenteric angina is also called as an intestinal angina, and that anginal pain comes with pain on eating. It is very commonly because of coronary peripheral vascular disease or abdominal bruit, or may be associated with coronary artery disease. The pain is usually in a periumbilical region. Good number of times there is an embolism secondary due to cardioembolism. Common cause of cardioembolism is atrial fibrillation. There may be intestinal infarcts. Acidosis may also aggravate intestinal infarct. Surgery may be required if there is an acute vascular occlusion. We have already discussed this particular differential diagnosis of stable angina, unstable angina, STEMI and non-STEMI in ischemic heart disease. So I am not repeating this. At your leisure time, you can go through. Usually in a stable angina, it comes on exertion. It responds to glyceryl trinitrate. Enzymes are normal. ECG is often normal. And you can confirm by exercise treadmill testing or by stress testing. While in unstable angina, usually you can come across ECG changes, troponin is normal in STEMI and non-STEMI. In STEMI, ST elevation, in non-STEMI, ST depression and troponin are elevated and they do not respond. Unstable angina, stable angina will respond to glyceryl trinitrate, while unstable STEMI and non-STEMI will not show any effect. Means pain will not be relieved by rest or by nitroglycerin. We are not going into detail at present. This is how you approach to any person with chest pain. We have already discussed in the chest pain chapter. So this is when you suspect an ischemic heart disease, how you approach. Investigations also we have discussed in detail in ischemic heart disease, but still repeating again: chest X-ray, ECG, echo, stress test, or we call TMT, treadmill testing, cardiac enzymes, troponin, CPK, MB, LDH1 is very rarely done. Risk factors like lipids, then inflammatory biomarkers, CRP, HSCRP, homocysteine level, and to demonstrate the viability, viable, non-viable, thallium scan, stress scan, PET, cardiac catheterization to find out the hemodynamic changes, echocardiography, stress echocardiography, CAT scan, coronary angiography with CT or MRI, ergonovin test, particularly to demonstrate vasospasm in vasospastic angina, etc. So these are all the different tests which can be done. We have already discussed in chapter of ischemic heart disease and also in case of chest pain. And even I have discussed in ST segment elevation. So these are the different tests which can be done. We have already told you that in case of a stable angina, ECG may be normal, or you may see only T wave changes or ST segment minor changes. This is in case of variant angina, you can have an ST segment elevation during chest pain and coronary artery spasm, and after rest or by drug, spasm is relieved, ECG changes will come back to normal and there will be no change in troponin. That's why it is labeled as vasospastic or variant or Prince metal angina. If person gets ST elevation and ST elevation comes back to normal at rest, variant angina, but if ST elevation persists, no effect on chest pain by rest or by nitroglycerin, goes more favor of STEMI. And if there is an ST depression, then it goes in favor of non-STEMI. So you can see here there is an ST depression. This will go more in favor of non-STEMI or unstable angina. I am not going to discuss in detail regarding a myocardial infarction. So infarction means total occlusion of coronary artery resulting into necrosis. You will have a Q wave appearance, you will have a ST segment elevation, and later on nearby area will show you in an opposite lead, we call reciprocal lead, you will see ST depression. Biomarker, we have already told you that troponin will be elevated, CPK-MB will be elevated. Myoglobin is also elevated, but it is routinely not done. We have already shown you this slide in an ischemic heart disease that CPK-MB will be elevated for 2 to 3 days. Peak value will be within 10 to 24 hours, while in case of troponin, it is 24 to 48 hours and it will be elevated for 3 to 5 days. Troponin is more sensitive as compared to CPK-MB. Usually LDH and AST are not done. Myoglobin being costly, again it is not done and it is lasting for very short period. Hence, it is not commonly done. Stress testing is done only in case of a person when person is having anginal pain but there is no STT changes. In that case, person goes for stress testing. And on a stress testing, if there is an appearance of an ST segment changes, say you start getting ST depression or downsloping, then it goes more in favor of stress test positive. You can see here, this is ST segment depression which has come. That goes more in favor. Or even during a stress testing, if there is an appearance of S3 sound, basal crackles, person gets fatigue or starts getting chest pain, that is also in favor. So these are the changes which you can, ST segment depression changes. If it appears on a exercise, then it is in favor. Additionally, you can go for nuclear stress testing or echo stress testing. You can go for dobutamide stress testing or angiography. And angiography is good number of time combined with CT or MRI. PET scan will give you an idea regarding a viable and non-viable or even ischemic, non-ischemic myocardium. Exercise stress testing is contraindicated if the person is having chest pain or is having unstable angina or person is having acute myocarditis or pericarditis, severe systemic illness, severe aortic stenosis, hypertrophic cardiomyopathy, congestive heart failure, severe hypertension, uncontrolled cardiac arrhythmia, particularly tachyarrhythmias. Stress testing is contraindicated. Coronary angiography will give you an idea regarding the severity, number of artery involvements, etc. And it also will be helpful to rule out MINOCA and INOCA. Blood test will be important to rule out stable angina from unstable angina, etc. Holter monitoring will be useful in the person even on a stress testing. If you don't demonstrate ST changes, you can, and if person is still getting chest pain on exertion, Holter monitoring can be utilized. Even MCOT is very helpful in a person who are getting chest pain occasionally. So when they get chest pain, they can record the ECG and send it to an expert by MCOT. MCOT is mobile cardiac outpatient telemetry, where person is having this instrument. As soon as he gets a chest pain, ECG recording will start. that will be recorded in this instrument. He can switch on this, ECG will be recorded. It will be transmitted to by wireless transmission to the center where an expert will read it. It will be given to his family physician, will read the data and he will give the specific instruction. This is also available now in India also. Ergonovin test, I have already told you that it is a stimulatory test done for ruling out coronary artery spasm. So if there is a normal ST segment in a person with a chest pain and you are suspecting coronary artery spasm, you can induce coronary artery spasm by giving ergonovin or acetylcholine and demonstrate ST elevation, which will suggest that person has developed coronary artery spasm. Cardiac catheterization will be helpful to find out the severity, particularly we call as angiography, will be helpful to find out the severity of the vessel involvement, number of vessel involvement, and then you can also subject them to PTCA or we call as angioplasty. And if that is not possible, person can be subjected to CABG. Even while doing a cardiac catheterization, you can also record the pressure gradients. In case of an acute coronary occlusion, you can go for thrombolysis. Coronary angiography will show you the exact site of narrowing of coronary blood flow. Differential diagnosis, you will have to differentiate all different varieties of angina and you should differentiate stable angina from acute coronary syndrome. Management will depend primarily primordial prevention where you want to prevent atherosclerosis, which is the most common cause of angina. Primary prevention is prevention of all risk factors so that the person does not get acceleration of atherosclerosis. Once the person starts getting anginal pain, during acute episode you give a coronary vasodilator sublingually and then you can maintain them on a drug therapy which will prevent angina. And if a person starts developing a symptom, even in spite of a drug treatment, and if the duration increases, frequency increases, and even if the pain comes at rest, do suspect unstable or we call acute coronary syndrome, investigate and treat accordingly. If a person of stable angina develops a symptom suggestive of acute coronary syndrome, accordingly you will have to treat. And if there is already acute myocardial infarction, now person will require a tertiary treatment, what we call as a thrombolysis with PCI or CABG. So risk factor modification, drugs, percutaneous intervention may not be required in a stable angina. Usually it is necessary in case of a acute coronary syndrome, and CABG is also required very frequently in a acute coronary syndrome rather than stable angina. And all patient with diagnosed stable angina should have a regular checkup and regular follow-up. Prevention of anginal attack and preventing a person of stable angina to go into acute coronary syndrome should be done. So always investigate the risk factors, severity of arterial disease. So treatment requires lifestyle modification, medication, surgical treatment, etc. So percutaneous intervention and CABG is usually required when the person do not get response to medicines or if the symptoms are worsening. By and large, during acute episodes, person requires a short-acting nitrates, and for a chronic therapy or for a long-term treatment, person requires a long-acting nitrate, or you can use CCB or a beta blocker. Or on the top of a beta blocker, you can use potassium channel. And along with that, lipid lowering drugs in a full therapeutic dose and antiplatelet or dual antiplatelet drugs. In some of the person, you might require even anticoagulants, particularly in case of an unstable angina or we call acute coronary syndrome. Surgery or intervention will be required only in a person who are having a very high risk of developing acute MI. Coronary artery bypass and balloon angioplasty or we call PCI is usually indicated in those groups with a high risk, and stent. Along with that, you require a control of blood pressure, rigid control of diabetes, quit smoking, stop alcohol, control lipids rigidly, weight reduction, avoid excessive physical exertion, mental stress, etc. There is one word which is utilized is MONA during acute episode. If a pain is unbearable, then morphine. Some person might require oxygen, usually nitroglycerin sublingually, and you have to give aspirin. So basically, you have to reduce oxygen demand and you have to increase the blood supply. So in case of an acute coronary syndrome, you might require a thrombolysis followed by PCI or CABG. So this is PCI, which is not very commonly required in unstable angina. This is PTCA, or also called as a percutaneous transluminal coronary angioplasty, and PCI is called percutaneous coronary intervention. Two terms which is utilized. Only the route of entry is different. This is PCI, this is CABG, this is CABG, this is PCI. Percutaneous coronary intervention. This is again, this is coronary intervention. When it is transluminal, word utilized we call PTCA. And this is percutaneous coronary intervention. That is a better word now. That is the most common word which is being utilized nowadays. CABG will depend upon the number of artery involvement, which artery is involved accordingly. Usually there are two arteries which are being available. Right internal memory, left internal memory. And if third is required, then you can use radial artery, or some people use saphenous vein. Usually nowadays radial artery is utilized. So these are the different methods. We have already shown you in ischemic heart disease video lecture that you can go for thrombectomy, thromboembolectomy, etc. Angina can go into acute coronary syndrome like unstable angina, and unstable angina can end up with STEMI or non-STEMI. So usually a stable angina can become unstable, that is acute coronary syndrome, and can end up with STEMI or non-STEMI. So I end my lecture here. I hope this lecture will be very helpful to you. Very frequently you will come across in your everyday practice. You should be able to pick up all these people and diagnose them